Hi, everyone. Thank you for joining us this Saturday afternoon. Welcome to the third part of our 5-part SIGNA Masters MSK webinar series. I'd like to firstly thank all the registered attendees and also the two speakers with us today. So I'm Eileen from GE Healthcare, your ASEAN MR marketing leader. I'll also be your host for the next hour. We are very lucky today to have two radiologists with us this morning, and we'll be focusing on the lower limb MSK MR imaging. The two specific topics that we'll cover today are post-op MRI assessment and MRI of the knee. So without further ado, I'd like to introduce our speakers. We have two MSK radiologists today. The first speaker would be Dr. Lim. He's a consultant radiologist at Singapore General Hospital, and he is also the Deputy Section Chief of the Musculoskeletal Imaging Section and Associate Director of the Singhealth Radiology Residency Program. The second speaker we have with us today is Dr. Stephen Wong. Dr. Stephen Wong is a musculoskeletal radiologist and also the head of department at Sengkang General Hospital, which is a brand new hospital for Singapore. And it's a huge hospital right at the northeast of Singapore. He sits on the executive committee of the ASEAN Musculoskeletal Society and is also the counsel of the College of Radiology Singapore. Dr. Wong's main interest is in imaging of articular cartilage, a topic which he has spoken very passionately about at several conferences and meetings. A gentle reminder that you're free to type your questions anytime throughout the presentation, and we will only take your questions at the end after both speakers has completed their presentation. There is also a like feature featured as a heart icon. So if you resonate with any particular slide and like what you see, do generously click on the like icon and let us know. So without further ado, I'd like to hand over the time to our first speaker. Dr. Lim, please.
Yeah, good morning, guys. Thanks to GE for inviting me. I hope everyone is doing well on a Saturday morning. I'm Yeong. Today I'm going to spend some time to share with you some of the most recent concepts on reading of post-operative MRI in the hip and the knee. Okay, let me just, okay. No disclosures to make. Okay, so in the next 20 minutes, I'm going to run through reading of the MRI hip after femoral acetabular impingement surgery. I'm also going to next run through reading of the MRI knee after meniscus surgery and ACL surgery. As for imaging of around arthroplasty or around metal implants, I think that's a very huge topic that we probably will have unfortunately leave it for our next talk in the near future. So by the end of this 20 minutes, you should be able to describe common orthopedic surgical procedures for internal derangements of the hip and knee. I hope you can identify the common post-operative appearances and know what complications to look out for on the post-procedure MRI. We'll start off with the hip, in particular, femoral acetabular impingement or FAI. We know that FAI is diagnosed through a triage of symptoms, clinical signs, and diagnostic imaging. The different types over here, you see the pincer type where there's an acetabular overcoverage, the CAM type where there's a fibro-osseous bump at the femur head-neck junction. Finally, there's a mixed type. Treatment choices we have are made up of either conservative care, rehabilitation, or more and more commonly these days, surgery. What's the role of surgical management? It's twofold: to provide symptomatic relief, reduce the pain, increase the range of motion, and secondarily, to prevent early onset of hip osteoarthritis. While surgeons are able to perform an open surgery, these days people prefer to do arthroscopy just because it's a more simple procedure with a shorter post-op rehabilitation period. Surgeons will start by doing a capsulotomy, cutting a small incision at the anterior aspect of the hip joint. And subsequently, depending on which type of FAI or what are the associated injuries, they will either do a femoroplasty or osteochondroplasty, where in a cam type impingement, they will use a burr to reproduce that normal anterior superior head neck femur head neck offset. For example, in this image, you see there's a fibroosseous bump here. They use it to shave it off to create this offset to allow for a wider range of movement. If it's a pincer type of impingement where there's a peripheral acetabular rim of osteophytes or over coverage, they will also use a burr to just shave off the peripheral aspect of the acetabular rim. We know that one of the problems with FAI is associated with labral tears. When they find a labral tear on the scope, they can either do a shaving off excision to make it smooth, or if they can repair it, they will try to repair it by putting in these suture anchors at the acetabular rim and either wrapping the suture around the torn labrum or through the labrum itself. So this arthroscopy images showing you acetabular tear and being reattached to the acetabular rim. They'll be also looking out for any chondral injuries. If there's an acetabular flap, we try to resect it, cut it away. And if it's a significant large area of cartilage loss, we can try to do a microfracture to try to get some new granulation tissue formation. Okay, so how am I going to approach reading the MRI post-surgery? I would like to correlate them with the surgical components in the next few slides. For example, when we're talking about arthroscopy and capsulotomy, what am I looking out for will be adhesions, capsular defects. When we're talking about the femoroplasty, I'm either looking for inadequate osseous resection or an associated stress fracture post-op. If there's labral repairs, then I'm also looking out for any recurrent or residual labral tears. Might be very difficult to differentiate, and also for any suture anchor malposition. Finally, we can also assess the cartilage again, looking out for any progress of chondral degeneration or any associated iatrogenic chondral injury post-op. So let's start off with adhesions, right? It's not uncommon. Studies show that up to 35% prevalence and actually can be seen in both symptomatic and asymptomatic patients post-op. What am I looking out for? This soft tissue thickening, intermediate to low signal intensity, commonly between the femur neck and the anterior capsule, like in this image here, or they can also obliterate the paralabral sulcus. So the normal paralabral sulcus pre-op, you see there's a small sulcus here, and on the post-operative scan, you see that it's kind of attached on and to the peripheral part of the joint capsule. This is definitely better visualized if you perform an MRI arthrography. Whether this is significant or not is controversial in the literature, but some authors actually believe that this might be a cause of soft tissue impingement, like for example at the anterior head neck junction, or in fact when they are stuck onto the labrum, it affects the sealing function of the labrum, resulting in persistent symptoms or even new labral tears. As we say, the surgeon, the procedurist will make a small cut in the anterior aspect of the capsule. And on post-operative images, quite commonly, we will see at least half or two to the time you see a small defect in the capsule. Again, studies have shown there's no clinical significance between symptomatic and asymptomatic patients, whether the defect is there or not. However, some authors actually believe that if the capsule is too big, they might lead to instability. For example, in this image here, this patient had a very large defect in the anterior aspect of the hip, leading to a secondary hip dislocation. As you can see, there's some iliopsoas muscle edema, and there's an impactation injury at the femur head due to the dislocation. So some surgeons even have advocated capsular plication in cases where the patient has a acetabular dysplasia. Okay, so most of the time, surgeons will do a femoroplasty for the cam type impingement. This is how it should look like post-op. Pre-op, you see that the fibroosseous bump leads to the loss of the head neck offset, and in the post-operative images, you see that there's actually a surgically made offset that allows for greater range of movement in the hip joint. This is how the acetabuloplasty will look like. It's shaved off the peripheral rim of the acetabulum. So what we're looking out for in this kind of this part of the procedure, in fact, this is very important. Most common cause of revision hip arthroscopy is actually inadequate osseous resection. So how do you measure that? Some people suggested that if you measure the post-operative alpha angle, it should be less than 50 degrees. We know the normal is about 55. In another study, they showed that the mean change is actually about 5 to 10 degrees. However, the same study also showed that when they did 42 patients, about half actually had less than 5-degree change. So some other authors actually suggested that instead of measuring the alpha angle, you should measure the resection depth and length instead. This is because, as we all know, the alpha angle kind of changes and due to interoperator variance and also which cut of the axial oblique sequence that you use to measure. For example, in this same images from the same patient post-op, you see that, and if you look at the axial oblique images, there's a good head neck offset that's been created surgically. However, the patient is still having symptoms, and you look at the coronal images, you see that at the lateral aspect of the head neck junction, there remains a fibroosseous bump. So this is persistent and causing patient symptoms, and the patient went for a repeat revision arthroscopy. So why don't surgeons try to resect more in the first instance? Because it's a bit of a trade-off. If you resect too much, the head neck becomes slightly more narrow and the patient is susceptible to stress fracture. Like in this case, you see that there's hyperintense stress fracture line with surrounding marrow edema. All right, it's suggested by some authors that if you should try to keep the depth of resection to less than 20 degrees of the femur neck diameter and the length of resection to 35 degrees to reduce the risk of fracture. Some other authors also suggested that if you see a persistent edema in the femoroplasty site for more than 3 months post-op, you might want to suggest that there might be some sort of stress reaction and make sure that the patient is advised accordingly. In quite commonly, patients also undergoes for either labral resection or labral repair in these FAI surgeries. When you note that the patient has a post-labral issue, you definitely should ask for an MRI arthrogram because just by distending the joint, it allows you to diagnose any recurrent tear, repeat tears better. Okay, so in this case, these two images at the top showing you a pre-op, you have a longitudinal tear that was slightly resected, and the post-op you get a short truncated labrum. This is normal. This is what you're expecting to see. So what is the criteria for a recurrent tear? I would honestly tell you it's not that easy to diagnose. You will need to have certain criteria such as a new line to the labral surface, a large distorted labrum, or a new paralabral cyst. So these two images at the bottom, axial obliques, you see that post MRI arthrograms, you see that in the pre-operative image, there's a slightly more oblique fracture line. And in the post-operative images, you see that this is a different type of configuration of the linear line. This is more horizontal. So this is diagnosed as a re-tear. Patient went back for a repeat check and that was confirmed arthroscopy. When they do a repair, they have to put in ankle sutures. It's also prudent to just make sure that the ankle sutures are placed in the right position, slightly above the cartilage type mark. So in these cases, these are where you expect them to see. And in this case, where the suture is placed too near the rim of the acetabulum and near the cartilage, is causing a secondary reaction in the cartilage itself. Finally, you also need to look at the cartilage. If it's a very focal injury in the cartilage that you didn't see preoperatively, you might want to look through the case note, discuss with the surgeon, is this an iatrogenic injury from an impactation injury from a arthroscopy scope. The other thing that we're looking out for is any persistent progression of cartilage degeneration. In this case, preoperatively, you still see a thin rim of cartilage, the gray zone here. However, post-op, you see a lot of thinning, irregularity, and partial thickness or full thickness defects. I think this has significant relevance to the clinician, so it's good to just document that down as well. All right, so we are good timing. We're halfway there. We're going to move down south to the knee now, which is actually more familiar territory to everybody. Definitely for myself as well, because you know that meniscal tears and arthroscopic meniscal repairs are so common, and it's a very major industry. So you will probably see these cases here and there again and again. We know that different types of tear, longitudinal, vertical, radial tear, and you know that where the tear lies in the transverse cut of the meniscus actually affects whether you can repair them or you just can have to reset them. Traditional thinking is that if it's in the tear is in the peripheral third of the meniscus, this is the red zone, when it's highly vascular, it's much better to repair them as they have good healing potential. If it's in the red white or the white, tend not to heal so well. Of course, there are caveats involved. So what do? Commonly, you do a partial meniscectomy. This provides symptomatic relief by removing the irritating flat component of the tear component, making it more smooth. Commonly done for more central tears like radial tears, complex tears, or even those kind of degenerative horizontal tears that fail conservative therapy. However, we know that as you reset more meniscus material, you increase the risk of, you increase the progression of osteoarthritis in the patient in the subsequent years. So whenever they can, surgeons will try to do a surgical repair of the meniscal tear, because this not only provides relief but also reduce the progression of osteoarthritis. So this table I took from the Campbell orthopedic textbook, you can see what are the criteria to do that point the tear towards a repair. There are many types of repair: inside out, outside in, or in. I'm not going to delve in them into details. However, I just want to highlight that for posterior root tears, these days people are very aggressive to do a transtibial pull-out. As you know that the posterior root tear results in a meniscal extrusion, loss of the hook strength support of the knee, and results in a rapid acceleration of osteoarthritis. So you might see this kind of procedures more often in your practice these days. Finally, very rarely in a small subset of patients, they have advanced irreparable meniscal injury, and they are younger than 35 years old. You might want to consider implantation of cadaveric meniscal allograft, and these are some very nice images showing you how an allograft is being prepared and placed into the tibial plateau. Okay, so let's go back to imaging. How do you assess them post-op? Normally, you should see some volume loss due to the partial meniscectomy, truncation or blunting of the meniscal fluid. That's normal. Okay, but of course, try to correlate with the clinical notes. If you see some increased signal intensity contacting the articular surface in intermediate weighted sequence, that's actually quite common as well. It's due to fibrovascular or granulation tissue that persists and may last for more than 10 years. Then you might ask me, if you see some increased signal, it could be just normal granulation tissue. How do you diagnose a re-tear? Okay, so that's where you really need to check with the surgeon what they do. If it's just purely partial meniscectomy, less than 25%, then all is good. You can feel very confident to diagnose any more re-tears because you are just depending on the traditional criteria you use for native knees, preoperative knees, meaning linear intrasubstantial increased signal intensity extending to the articular surface on two planes, either in the same, consecutively in the same plane or same region in two different planes. Or in fact, if you have a meniscal fragment that's displaced, definitely that's going to be a re-tear. If there is partial meniscectomy for more than 25% of the meniscus, or there is a repair, then you have to depend very heavily on your T2 weighted fluid sensitivity sequence, or if even better, you have a gadolinium sequence in the MRA. So you need 2 or more sequences that shows definite surfacing T2 fluid signal or gadolinium signal, or you want to see a displaced meniscal fragment. Okay, so these images put things to perspective. In the first 2 images, this is just a post-operative signal change at the posterior horn. You see some signal cleft, but it's not really very high fluid signal on the fluid sensitive sequence. The images to the bottom, you see a truncated meniscus, but on the fluid sensitive sequence, you actually see horizontal cleft of fluid signal extending into the articular surface and going out, associated with parameniscal cyst. This is a re-tear and confirmed on repeat arthroscopy. So I mentioned something about MRI arthrography. Does it help? Should you do it? Studies show that if you have access to direct or indirect MRI arthrography, definitely will help you be more accurate in diagnosis of re-tear post either partial meniscectomy or repair. However, I would say that even in my institution, we don't really do it routinely for the knee because definitely it's a more invasive procedure And some studies show that it's not 100% as well, because sometimes the granulation tissue at the outer margin leads to some pitfalls that the gadolinium doesn't go into the re-tear itself. So just take it with a pinch of salt in some ways and weigh the pros and cons of whether you want to put your patient through this arthrography. I mentioned something about the root repair. I think the surgeons will appreciate if you describe how the healing process is happening in the repaired root attachment. So there's some guidelines, criteria suggested in the literature. If it's nice and dark like this is a completely healed root attachment, all is good. If some high signal is incompletely healed, you're not really sure there's a partial tear or not. But if there's a fluid cleft, fluid signal, then definitely you are worried about a re-tear. The other important thing you want to highlight is any progression of meniscal extrusion, as you know that the posterior root tear is associated with meniscal extrusion affecting hoop strength. Okay, coming up to the last part of the meniscus, allograft transplantation. Honestly, I don't see this very often, and it's not that easy to interpret because there are a lot of findings of indeterminate clinical significance. For example, the meniscal graft may maintain a very high slitting intensity from up to 6 weeks up to more than 6 months. Graft shrinkage is a very common issue. Nobody really knows whether it's associated with symptoms. Patients tend to have some sort of graft extrusion as well. Again, it might happen in asymptomatic patients, but if it's a really huge piece, for example, like this, I think you really better describe it to your surgeons and make sure that they correlate with clinical findings. Okay, last few minutes, quickly run through ACL tests. The intention for treatment is also again to provide some stability to the knee, relief, and also reduce the progression of knee OA. More commonly, we do ACL graft reconstruction, and this is the gold standard bone patella tendon bone, a stronger type of graft reconstruction, however, associated with some high incidence of post-operative anterior knee pain. So these days, hamstring grafts using semi-tendinosis and gracilis is getting more and more common. Less post-operative anterior knee pain, slightly weaker kind of graft. Recently, there's also a lot of interest in literature on this ACL primary repair for those kind of proximal tears that can be repaired primarily using some internal scaffolding. So in this post-operative image, you see that at the initial onset post-op, you get a very high slitting intensity, and subsequently becomes slightly more low slitting intensity as the ligament heals. What are you looking out for? The main things, I can't tell you everything because I don't have much time, but I'm just going to say that you look at the graft tunnel, we know that the tibial tunnel should be posterior to the Bowman-Stacks line, which is the intercondylar roof line. If it's too far anterior, in like this case, you might cause some impingement when the knee flexes and extends, so resulting in some signal change here. Also, the femoral tunnel should have a slight angle up to 11 o'clock, 1 o'clock, depending on left and right, so to allows for some more stability. If it's more vertical, there's really not much stability being produced. ACL graft signal can be divided into, depending on when you scan it. Early phase, less than 4 months, should be low. 4 to 12 months, it can be intermediate to high slitting intensity. But after 1 year, usually it goes through a ligamentization, so it should be low in slitting intensity again. But this is not always the case. There might be persistent high signal that lasts more than a year, so you need to interpret this with some caveats as well. And also depending on what type of graft, is a bone patella tendon bone graft, usually low homogeneous, low slitting intensity. If it's a hamstring tendon, it tend to give a striated appearance because it's made of 4 bundles. So how do you diagnose re-tears from this kind of vascularization phase? You really need to look at increased signal density or T2-weighted sequences. Fluid sensitive sequences is your friend. And definitely, if you have some fiber discontinuity, for graft thinning, this is really pointing you towards a graft tear. There are also some secondary signs that help you: anterior tibial translocation about 7 mm, undercovering of the posterior horn or lateral meniscus, or any PCL buckling. There are a lot of other complications which I have no time to go through, but just look through. If you can look at this radiographics paper in 2009, summarizes all these conditions very nicely. So I'm coming to the end of my talk. Some take-home messages. You need to appreciate the various surgical techniques, and so that it can help you understand the expected post-operative morphology better. And post-operative MRI is definitely the most useful diagnostic tool to assess of complications in symptomatic patients. And still, there are much potential to improve imaging techniques to diagnose re-tears, for example, in labral repairs, meniscal repairs, ACL grafts. Like I mentioned, there are some parts that are very difficult to interpret. So these are some of my references. So that's the end of my talk. Now I will hand you over to my friend, very good friend and mentor, Dr. Stephen Wong, to carry on with his talk on cartilage imaging. Yep, thank you.
Hello. Okay, so two things are going to happen. First, I'm going to turn off my webcam, and then I will share screen. Okay, so I do apologize if you hear some knocking noise. My neighbor has decided to change his air conditioner today. I do apologize for that. So without further ado, let's go through. I'll be talking about MRI of the knee joint, a very brief run through. These are my disclosures. Okay, so we need to remember that the knee is a huge joint with three main compartments, right? And we should keep in mind that whatever happens in one part of the joint will affect the other parts of the joint as well. Okay, so these are the routine sequences that are done in my department. We do a coronal T1, coronal T2 or PD, which is my favorite. Actually, that's all you need. We do a sagittal and sagittal oblique and axial. And we'll also do DWI or ADC for masses. And I've had experience with gradient echo, but since I'm so used to looking at PD sequences, I more or less stopped doing gradient echoes. So briefly, let's go through the corners of the knee. So as you know, there are four main corners: anterior lateral, posterior lateral, posterior inferior, and anterior medial. Okay, so we'll go from one to the other. So the anterior lateral corner of the knee includes the joint capsule, the iliotibial tract, which inserts at the Gertis tubercle, the anterior oblique bed, anterior lateral ligament, is nicely demonstrated in this graphic here, and the lateral femoral tibial ligament, and the posterior lateral bundle of the anterior cruciate ligament. Next will be the posterior lateral corner, or also called the arcuate complex in some of the literature. This is rather busy area. You have the lateral collateral ligament, you have the proctus muscle and tendon, you have the arcuate ligament at the back, which is more or less a focal thickening of the posterior joint capsule rather than anything. And most times you don't see it unless it's disrupted or injured. You also have contributions from the long and short head of the biceps femoris, lateral head of the gastrocnemius muscle, as well as popliteal fibular ligament, and the popliteal meniscal fascicles, and the oblique popliteal ligament. Next, we'll go to the posterior medial corner. On this graphic, you can see the posterior oblique ligament, which is a component of the medial collateral ligament. You have superficial and the deep sections of the medial collateral ligaments, but here you can see that the MCL is actually disrupted on this nice graphic here. You have the membranous, semi-membranous tendon, as well as the medial head of gastrocnemius muscle. And last but not least, the anterior medial corner, which includes the medial collateral ligament, the anterior band, which contributes to the medial patellofemoral ligament, the anterior medial bundle of the ACL, as well as the medial patellar retinicular fibers. Okay, so in this instance, you can see that the medial patellofemoral ligament is disrupted. It should have a dark, bright, dark appearance when it's intact, but usually is torn if there's instances of lateral patellar subluxation. Point to note, in a normal usual setting, when we scan the patient, the medial collateral ligament is located anterior to the lateral collateral ligament at their insertion point to the distal femur. Okay, let's briefly touch on the pes interinus, or as people say grace before T, ma'am, which includes the sartorius, gracilis, semitendinosus, and semimembranosus. In instances, the semitendinosus may actually be posterior to the semimembranosus on certain planes of your axial sequence. So you just really need to follow it down as it goes down to insert to the tibia. So let's have a brief look at this case. So we have a 25-year-old who fell onto his right knee during a basketball game. You can see that anterior cruciate ligament is torn and it's now lying horizontally. there is a tear of the posterior horn of the medial meniscus, and is in the red zone, white zone area. Okay, and if you notice on the sagittal and the axial, we can see a synovial plica, which can actually get caught between the femoral condyle and the patella and get and form some form of impingement syndrome. So in this case, you have a case of intervenient subvernal plica. Okay, so moving swiftly on, this 36-year-old sustained injury during a soccer game, and you can see definitely an ACL tear, but what looks to be a double PCL. So double PCL means that there is going to be a bucket handle tear, either of the medial or lateral meniscus. Okay, so here you can instances where you can see the flip aspect of the bucket handle tear from the medial meniscus, and on the axial there, where he has come from the posterior horn, flip forward anteriorly, right, and is causing some form of impingement. Okay, so Yeong nicely went through all most types of the meniscal tears that we can see. This is just very nice graphic. If you're lucky enough and your MR technologists are friendly enough to you that day, they will do a nice axial sequence through the meniscus, and you can see roughly the medial and the lateral menisci on this image here. Okay, and this actually axial image I found has been a lifesaver at times, because sometimes there are tears that you don't see on a sagittal or a coronal sequence, but do appear on the axial sequence. So the common tears are longitudinal tears, usually at the red zone, white zone junction, radial tears on the inner edge, and a vertical flap, or the commonly known parabic tear. You also have the horizontal tears, which tend to be more degenerative in nature. Right, so in this case, you have a radial tear, but you can see it on the sagittal as a white area at the inner edge of the meniscus. But on the axial, we can see a fluid cleft within the inner edge of the meniscus. So the axial is very helpful in this case. This 15-year-old sustained injury during a rugby match, and you can see an ACL tear, but also at the same time, bucket handle tear of the lateral meniscus. So if you look at the coronal sequence, you can see that the lateral meniscus does appear strange. It's a bit deficient. There seems to be some weird soft tissue lying around. You can see a double PCL sign on the sagittal sequence. And if you follow it out through enough, you will see that somehow, for some strange reasons, the anterior aspect, the anterior horn of the lateral meniscus seems to be doubled up. So this is what likely going to be a bucket handle tear. Right, so this 39-year-old sustained an injury to the left knee. So there is a PCL tear, okay, ACL looks okay. Medial collateral ligament looks torn and strained. Lateral collateral ligament also thickened and edematous, lightly strained. There's also injury to pes and serinus. But let's not stop there. Always look for other injuries. And if you look properly, there is a radial tear of the posterior horn of the medial meniscus, and the axial that demonstrates this nicely. And if you didn't see it, here it is. Okay, so radial tears can be partial thickness or full thickness. Once you have a full thickness radial tear, you end up with extrusion of the body of the meniscus. Moving on. This is just to better demonstrate the injury to pes and serinus, where the insertion. So you do need to trace the pes and serinus tendons all the way down to where they insert. So in this case, I cut off the lower portion of the image to try and fit it into the screen, but it is there. Okay, so this 32-year-old had a previous knee injury, now presents with pain. On first instance, you can see an ACL tear. And in patients with chronic tears of ACL that may or may not have been repaired, sometimes you develop what we call an arthrogryph fibrosis or cyclus lesion, as Yeong mentioned in his talk. This patient also has a vertical or longitudinal tear of the posterior horn. So this is what has demonstrated as the red zone versus the white zone tear, where the red zone receives blood supply. The white red zone is indeterminate depending on how good your blood supply is. And normally the white zone of your meniscus gets its blood, fluid and nutrients from the synovial fluid and don't tend to repair very well. Okay, moving on. This patient presents with a lateral pain, and during the scan, we notice that there is a horizontal tear at the external border of the lateral meniscus, with all these fluid-like structures extending out. This is actually what commonly known as parameniscal cysts. They can be focal and just stay in one location, or they can extend through and penetrate some of the ligaments or the joint capsules to become extra articular, as you can see in this instance. Don't biopsy them, please. Okay. This is a 26-year-old with vague knee pain after walking. I almost missed this. I tend to have a blind spot when it comes to discoid meniscus. So if you look at a coronal sequence, you will notice that the lateral meniscus in this aspect seems to extend from the outer edge to the inner edge, while the medial meniscus sort of tapers off nicely towards the mid section of the articular surface. All right, so they can cause impingement, they can tear easily. So you have the Watanabe classification of meniscal tears for involving discoid meniscus. Okay, so the generally accepted is more than 13 millimeter from medial to lateral, and they're commonly prone to horizontal tears. So is this a tear or is this a tear? So this is actually a meniscal flounce, which is a lax or redundant aspect of the inner edge. It's not a tear, but it can cause some discomfort to the patient if perhaps symptoms of locking. So this leads to the question, when it's a tear, not a tear? The answer is when it is flounce. But is this a flounce? No, actually. So this is a parabeak type of tear. So you can see it's a lot more wavy than you expect for a meniscal flounce. And if you look on the axial, you can see the parabeak obliquity of the tear within the inner edge of the meniscus. So when it's a flounce, not a flounce, basically when it's a tear. So that's a joke of today, okay? So in this 18-year-old with sustained lateral patellar subluxation, you can see the standard bone marrow edema pattern involving the anterior inferior medial aspect of patella and the lateral aspect of the lateral femoral condyle. They usually have associated injuries, including tears of the medial patellofemoral ligament. When you see such a case, then you want to see whether the patella is high riding, as in this case. So I tend to use the inside-Savati ratio, where you look at the tendon length, patella length, and you divide the tendon length over the patella length. And if the ratio is over 1.5, then you tend to have a high riding patella, which makes you more prone to lateral patellar subluxation. You also measure the TT-TG, which is the tibial tuberosity to tibial trochlea distance. And if it's more than 15 millimeter, then it means that there's lateralization of the tibial tuberosity, again, making the patient more prone to lateral patellar subluxation. Don't forget about the fascicles, which are present on both the medial and lateral, as well as the posterior aspect of the joint, which connects the meniscus to the joint capsules, and they can be disrupted individually. In this case, we have a 28-year-old who sustained a pivot shift injury, where you have the femur going in one direction and the tibia going in the other direction. And usually it's when the foot is planted and locked to the ground and the subject attempts to pivot and twist around to try and get the ball in a game, in a football match. So you get a bone marrow edema at the posterior lateral or posterior aspect of the tibial plateau, lateral tibial plateau, and at the outer central part of the lateral femoral condyle. They frequently will have ACL tears. So there's another patient with pivot shift injury. So it depends on the extent of the marrow edema, depends on when you actually scan the patient. Obviously, the earlier you scanned and if there's significant injury, you can do the more extensive the marrow edema. But in this case, you will see the O'Donoghue's triad of the ACL tear, MCL tear, and then the medial meniscal tear. This patient also injured the patellar tendon, the posterior oblique ligament on the medial aspect, and the lateral collateral ligament as well. So it's quite an extensive injury. So let's talk about the bundles. The ACL has two bundles, the anterior medial and the posterior lateral, and sometimes they can be separated in this case, or they can be torn individually. So you need to be cognizant of that. In this 46-year-old who sustained a quadriceps tendon tear distally, sometimes can be quite subtle, and you can pick it up clues on the coronal, but the sagittal will be the one that gives you the diagnosis. You can see a fluid cleft extending through the patellar tendon. In this case, because this is complete tear, we actually had to use the air coil due to the size of the leg. The patient couldn't fit into the standard knee coil. So quadriceps tendon has three main layers. The outermost, most superficial layer is actually the rectus femoris tendon. The middle, which is a bit thicker, is the vastus medialis and lateralis tendon, and then you have the vastus intermedius tendon. It continues on in front of patella as the quadriceps continuation, and that is mostly contributed to by the rectus femoris rather than the vastus malar tendons, and joins with the patellar tendon in a form of an aponeurosis. So this is another case where the patient could not fit in standard knee coil, so we actually had to use an air coil which we wrap around the knee joint. Not optimal, but you can get reasonable quality images. So this patient has a subtle tear of the anterior horn, and if you can see, there is some early chondral changes on the medial aspect and lateral aspect of patella, indicating that the patient is developing some patellofemoral osteoarthritis. When we talk about PCL tears, you can see the avulsion injury where the posterior tibial insertion point of the posterior cruciate ligament. This never happened in isolation, so please look at the anterior cruciate ligament. Is it torn or not? Look at the medial collateral ligament or the medial meniscus or the lateral meniscus. And in this case, you have tears to the ACL and the medial meniscus. All right, so Yeong talked about meniscectomy in great detail, which is, and it was a very good section. All right, so previously, meniscectomy, partial or full meniscectomy was very common, but thankfully it's less common now as realization that it leads to secondary osteoarthritis. Here you can see a patient who had partial meniscectomy, and you can see the frayed edges of the posterior horn or the medial meniscus, and you can see the extent of degenerative changes in the medial femoral tibial compartment or the knee joint because you've lost the protective effect of the meniscus on the articular cartilage. So if you have injury to your ACL and you have repaired, that's good. But you know, you can see the sequence from 2011 to 2016. You can see quite rapid progression of osteoarthritis after trauma or surgery, unavoidable. Okay, so in this 69-year-old, sorry, patient presents with posterior knee lump. I do have a radiograph. I don't know what happened to it. Maybe I deleted it. So you can present on MR imaging. You can see a Baker's cyst posteriorly between the medial head of the gastrocnemius muscle and the semimembranous tendon. It's actually named for a 19th century surgeon. So DWI, you can see fluid restriction and confirmed by the ADC. Okay, so they can be of varying sizes and can extend proximally or distally. To assess the cartilage, nowadays we have T2 maps that we can do. So if you can have a look, these two are actually the same axial image slice. I've just changed the window parameters on this to better demonstrate that there is some signal change in this aspect of the cartilage. And when you do a T2 map and you do a color overlay, and you can see where the color changes are to give you a better idea where the chondral defects or chondral injury is. So I find that T2 maps are very helpful, especially for initial setting of knee pain without appreciable radiographic changes, and when the surgeon's interested in disease-modifying behavior. So in this case, on this axial image of the patella, you can see an area high signal change in the lateral patella articular cartilage. And when we do a TG map, you can see the color changes there within the mid-range of the relaxation value, indicating some degree of injury to the cartilage at that point already. Okay, so this is a quick demonstration. On this radiograph, you can see hints of air fluid interface on the lateral view. MR definitely demonstrates it. So you can see lipohemathurosis within the axial and sagittal sequence, and this is due to a fracture of the posterior lateral aspect of the tibia. Don't forget the popliteal artery. Okay, so I've not seen one, but do look out to see where the position of your popliteal artery is, in case you miss a case of popliteal artery entrapment syndrome. The other thing is, if you look at a synovial lining, just because it's thickened doesn't mean that there's active synovitis. So in this case, the synovial lining actually looks reasonable, but once you give intravenous contrast medium, you can actually see that it quite enhances quite rapidly. In this case, this is florid synovitis. Okay, so this is my second to last slide. In conclusion, MRI is common. Rarely, just one structure is injured, and you need to keep in mind the whole joint injury concept. For my reports, I normally look at alignment first, then I look at the bone to see whether there's bone marrow edema and present osteophytes or degenerative changes. Then I'll look at the cartilage in all the various compartments, looking at the thickness, signal changes, whether they lost the stratified pattern. Then I'll look at the meniscus and the ligaments and the rest of the structures around the knee joint as well. This is the last slide. You can email me for if you have any questions after the session. So now it's back to Eileen from GE. Thank you.
Thank you, Dr. Wong, and also thank you, Dr. Lim, for the first presentation. Amazing cases that you guys have shown, very technical. Thanks for showing us what to look out for when it comes to MRI of the knee and possible pitfalls as well.